Hey guys, welcome back to Discussions with Dr. G. Today I'm discussing medications that affect cardiac rhythm. I'm Dr. G, your sarcastic nursing professor who's probably crocheting while reading EKG strips. Today we're diving into antidysrhythmics, basically the reality show contestants of the cardiac world. I mean, the heart's electrical system is like a toddler with mood swings, and these medications are the babysitters. Some are great, some, not so much. So let's break down the main classes. Class 1A, think quinidine and procainamide. These slow conduction and stretch out repolarization, which is just a fancy way of saying that they help the heart chill out between beats. But, and this is a big but, procainamide can cause a lupus-like syndrome. Yeah, you heard me. Suddenly your patient's joints are achy and you're like, wait, did I sign up for rheumatology? No, it's just the procainamide. Also, watch out for wide QRS complexes on that EKG strip. And if they're on it long term, you want to keep an eye on their ANA titers, okay? Class 1B, it's all about lidocaine. This one's for those wild ventricular dysrhythmias. It shortens repolarization, but there's a catch: neurotoxicity. Signs and symptoms include confusion, tremor, or even seizures if you're not careful. I always say if your patient starts acting like they're in a weird dream sequence, check their lidocaine level. Oh, and don't use it if your patient has severe heart block or WPW syndrome, Wolff-Parkinson-White. It's a heart condition where there's an extra electrical pathway in the heart that leads to episodes of tachycardia, syncope, palpitations, dizziness, and lightheadedness, with the inclusiveness of chest pain or chest tightness. All right, moving on. Class 1C. Flecainide and propafenone. Okay, these are the big guns. They are not going to be your go-tos unless things are really going sideways. They slow conduction a ton, but they can also actually cause new arrhythmias and blurred vision. And if your patient has structural heart disease, it's just a no. Then we've got the class 2, our fun beta blockers, metoprolol or esmolol, propanolol. These are the chill pills, literally. They slow the heart rate and conduction by blocking sympathetic stimulation, but they can also cause bradycardia, hypotension, and if you pick a non-selective one, bronchospasm. All right, class 3, amiodarone. Amiodarone is a drama queen. She prolongs repolarization, but she comes with a laundry list of issues: pulmonary toxicity, thyroid and liver problems, and my personal favorite, blue-gray skin. Seriously, who wants a patient that looks like a Smurf? Sun protection is a must with this medication. Class 4. These are our CCBs, calcium channel blockers, verapamil, and diltiazem. These slow conduction through the AV node, which is great if you have supraventricular tachycardia, also known as SVT. They also will control the heart rate a little bit better for patients who have AFib, but they can cause bradycardia, hypotension, and constipation. You want to avoid CCBs in severe heart failure, and always keep an eye on blood pressure and heart rate. All right, so then we have our other category. This is where adenosine comes in. This one literally stops the heart for a second to reset it. It is best used for severe SVT. okay? It's wild. You slam it in fast, flush it, warn the patient before you do this because they're going to feel like they're dying for a few seconds. And no, I'm not kidding. They will literally feel like they are dying because that is what you're doing. You are stopping their heart. So before you do this, you want to warn them first. All right, the last med in our other category is digoxin. Digoxin boosts heart contractility and it also slows the heart rate. So it slows it down and makes it pump harder, okay? But you've got to watch out for toxicity. Yellow halos, nausea, and anorexia. All right, let's talk key drugs, side effects, and contraindications. Zooming in on those big players. Class 1A, quinidine, procainamide. You're watching for diarrhea and hypotension. Like I said, lupus-like syndrome with procainamide. If your patient starts complaining about joint pain, please don't just hand them an acetaminophen and move on. All right, 1B is lidocaine, neuro stuff, big risk, right? If your patient's suddenly confused or twitchy, check that level. All right, class 1C, propafenone and flecainide. Heavy hitters, remember? Heavy. So heavy that they are used with extreme caution. They can not only cause bradycardia, hypotension, and bronchospasm, but can also cause heart failure or exacerbate existing dysrhythmias, potentially causing new ones. Who's up for a game of Russian roulette with cardiac dysrhythmias? Yeah, me neither. All right, class 2, metoprolol, bradycardia and hypotension. Esmolol, always checking the heart rate before giving it. And if it's under 50, just hold it. No one wants to explain to the doc why their patient's heart rate is in the 30s. All right, beta blockers are known to help slow the heart rate and decrease blood pressure. It is literally their whole purpose. But if their purpose becomes too hyped, they can cause bradycardia, hypotension, fatigue. Don't get me started on giving a non-selective to asthma patients because now you have to worry about those pesky bronchospasms. All right, so here's our remember. All right, remember with beta blockers, starting with letters A through N, cardioselective, meaning that they act more directly on beta 1 cells, and we only have one heart. Okay, so your A through N's are acting more directly on the heart. If the medication starts with letters O through Z, they're non-selective, meaning that they act on beta 1 and beta 2 cells. 2 types of cells, 2 lungs. Got it? All right. And if they sound like Olol, but they're not spelled Olol, like labetalol or carvedilol, right? They sound like carvedilol, labetalol. It sounds like Olol, but not quite spelled correctly. It means that they are also non-selective, and they are going to act on alpha, beta 1, and beta 2 cells. All right? So, heart rate under 50, hold it. Patient has any kind of respiratory concerns, make sure it's cardioselective. Remind your patients to change positions slowly, at least until their body acclimates to the medication. All right, class 3, amiodarone. It's a whole saga. Pulmonary toxicity. So if your patient develops a cough, don't just blame allergies. Blue-gray skin, that's not a new Instagram filter. And don't forget about thyroid and liver issues. Okay? All right. Class 4, calcium channel blockers, specifically verapamil, bradycardia, constipation, hypotension. If your patient's bowels have stopped moving, it might not be the hospital food. All right. Adenosine. Adenosine has a super short half-life, but the side effect is basically terror. Warn your patient. Push it fast and flush right after. If you don't warn them, they're going to think you tried to kill them. All right, digoxin. Digoxin. Nausea, vomiting, arrhythmias, and those wild vision changes. If your patient says the world looks yellow, don't just nod and smile. Check that dig level. And remember, hypokalemia makes toxicity way more likely. Contraindications, don't give it if your patient's in VFib. It's just a no. All right. Let's sum everything up. So how do you keep your patient safe with all these drama meds? First, EKG vigilance. Seriously, you're going to get tired of looking at these squiggly lines, but I promise you it's going to be worth it. Always check your apical pulse before giving digoxin for a full 60 seconds, no shortcuts. And with adenosine, warn your patient. I can't say that enough. You're going to feel weird, but it'll pass. Okay? It saves you a lot of panic looks. Balancing benefits and risks is the name of the game. If something feels off, question the order. Call the provider, or if you're still a student, talk to the patient's nurse. I know it's intimidating, but trust your gut. All right, that's a wrap for today's Antidysrhythmic essentials. Remember, these meds can save lives or cause chaos, so stay sharp. Trust your instincts and don't be afraid to ask questions. We will dig into a slew of new meds next time, so stick around. And if you're listening while crocheting, I hope your stitches are as steady as your patient's rhythm. See you next episode.